In terms of the median time to death or distant metastasis, there was a clear difference. However, it did not, I think, yeah, it did reach statistical significance. Now, the same authors have done outcome analysis by the level of PD-L1 expression. And look at all the hazard ratios over here. So irrespective of the level of PD-L1 expression, whether it's more than 25% or less than 25% or something in between, there was always benefit with addition of durvalumab. The only area where it did not benefit was when PD-L1 expression was less than 1%. So it did not have an OS benefit. Otherwise, it still had a progression-free survival benefit. This is another trial, the Keynote 001 phase 1 trial, in which the authors assessed how radiation and pembrolizumab combination worked in non-small cell lung cancer. So originally it was a phase 1 or phase 2 trial testing pembrolizumab for metastatic non-small cell lung cancer that had progressed during or following first-line chemotherapy. Total of 97 patients were accrued. The dose of pembrolizumab was either 2 mg per kg or 10 mg per kg every 3 weeks or 10 mg per kg every 2 weeks until there was disease progression, unacceptable toxicity, or other protocol-defined reasons for discontinuation. On secondary analysis, while testing for PFS and OS in patients who had received any prior RT, that is constituted about 43% of those versus those who did not receive any RT prior. So they did find that whenever we give RT in addition to pembrolizumab, there was a PFS and OS benefit. And this was stratified based on whether the RT was extracranial or intracranial, and there was still benefit persistent. Another important trial in this regard is the PEMBRO-RT trial, especially because it uses SBRT followed by pembrolizumab. It is a multi-center randomized phase 2 study with 78 patients. Accrual was done independent of PD-L1 status. The target population was recurrent metastatic non-CNS mets, non-small cell lung cancer. The randomization was between Pembro alone every 3 weeks versus SBRT followed by Pembro. The dose of SBRT, usual site was the lung or the lymph node, in a dose of 24 gray in 3 fractions, 8 gray per fraction. The Pembro was continued until either of radiological disease progression or unacceptable toxicity or patient withdrawal of consent. The maximum usage allowed was for 24 months. The primary endpoint they wanted to assess was overall response
Karan,
rate.
just a second. The mother is locked in.
The secondary endpoints were safety, OS, PFS, and disease control at 12 weeks. So this is the consort diagram. 92 patients initially assessed, 78 randomized, and because of various reasons, finally 40 included analysis from the Pembro arm and 36 from the RT arm and the Pembro alone arm. So if we compare the objective response rate at 12 weeks, the SBRT plus Pembro arm showed a 36% overall response rate at 12 weeks, whereas it was only 18% in the control arm. With respect to the disease control at 12 weeks, 64% in the experimental arm versus 40% in the control arm, and these differences were clinically significant. However, with PFS and OS, there was no statistical difference. The authors attributed that maybe the patient numbers were too small to detect such a difference. The subgroup analysis showed that the largest benefit from the addition of radiotherapy, that is SBRT, was in patients with PD-L1 negative tumors. Now, these results are contrasting to those shown by the durvalumab trial. Also, the response rate in the combined PD-L1 positive subgroups, that is PD-L1 more than 1%, was much higher as compared to the older trials. 52% here versus 18 to 27% in the other trials. And there was no increase in treatment-related toxic effects with the experimental arm. So this raised a number of questions. The authors felt that maybe a larger trial is needed to determine whether SBRT activates the microenvironment, potentiating the effects of immunotherapy. What would be the appropriate SBRT schedule, whether the 8 gray into 3 was good enough, and whether irradiating more than one site can generate a better immune response. So what they did was they accrued patients from a similar MD Anderson trial. They did a combined pooled analysis of these two trials. So with that, the patient numbers increased. With Pembro alone, they had 76 patients, and with the Pembro plus RT, 72 patients. In the MDACC trial, the SBRT dose schedule was slightly different. 50 gray in 4 fraction, and also hypofractionated RT 45 gray in 15 fractions was allowed. So with this, they could finally demonstrate a survival difference. Median PFS was 9.9 months versus 4.4 months in the Pembro-RT. Median OS was 19.2 months versus 8.7 months in the Pembro-alone arm. Coming to the next slide, prostate cancer. Not many studies are here as compared to CL lung, and the randomized evidence is also not there. But of note, important to mention is Sipuleucel T, which was the first cancer immunotherapy approved by US FDA for treating asymptomatic or minimally symptomatic metastatic castrate-resistant prostate cancer. It is an active cellular immunotherapy which consists of autologous peripheral blood mononuclear cells, including the APCs that have been activated in vitro with a recombinant fusion protein, which is called the PA2024. Now, PA2024 consists of a prostate antigen, which is prostatic acid phosphatase, which is fused to GM-CSF, which is an immune cell activator. Peripheral blood immune responses and cumulative product parameters like APC number, APC activation, and total nucleated cell number have been known to correlate with OS in patients treated with Sipuleucel T. The first randomized evidence of efficacy for this drug was by means of the IMPACT trial, which showed that in this 512 patients were randomized to either Sipuleucel T 341 and placebo 171. Prior radiation to prostate or prostate bed was received by roughly half of the patients in both arms, and it showed that there was relative reduction of 22% in the risk of death as compared to the placebo group. This was accompanied with a 4.1 month improvement of median survival, 25.8 months in the Sipuleucel T group versus 21.7 months in the placebo group. The 3-year survival probability was 31.7 in the Sipuleucel T versus 23% in the placebo group. The time to objective disease progression was similar in both groups. The T cell and humoral immune responses to the prostate antigen were observed in patients receiving Sipuleucel T, and they correlated with survival. But things to note are that Sipuleucel T is recommended only for asymptomatic or minimally symptomatic metastatic CA prostate patients. The adverse effects reported are mainly fever, chills, and headache. It is not beneficial in patients with visceral, for example, liver mets, not for patients with life expectancy less than 6 months, and not beneficial in small cell or neuroendocrine CA prostate. Due to the likely suppressive effect of radiation on bone marrow function and immune responses, previous studies evaluating Sipuleucel T have excluded patients who received RT within 28 days prior to Sipuleucel T. This is a relatively recent trial in this regard. Now, the old trial was of 2010. So in between, there have been numerous studies, but Sipuleucel T in combination with radiation has not stood the test of time. So we need more studies before we can take this into regular practice. Otherwise, as an individual therapy in metastatic CRPC, it is, as part of the NCCN guidelines, it is recommended in first line. These are some of the other trials which were done with prostate cancer, all with mixed response, and it's more of work in progress. The other important side is metastatic melanoma, mainly with respect to brain mets. And Ipilimumab was the first immunotherapy which was approved for treatment of metastatic melanoma in 2011, and also its combination with anti-CTLA4 and anti-PD-1 was also reported to have a higher synergism. So in this study of concurrent radiation and Ipilimumab for patients with melanoma by Barker et al., they demonstrated that immune-related adverse events were observed in 43% of patients receiving Ipilimumab at 10 mg per kg, and in 22% of patients who received 3 mg per kg. This was similar to previous studies of Ipilimumab alone. But radiation-related adverse effects were significantly more common in patients receiving higher doses of radiation. And palliation of symptoms was reported by as much as 77% of patients. There was an OS survival also, along with addition of radiation and Ipilimumab, 9 months versus 39 months in the combination arm. This important study by Pike et al. Structured on metastatic brain lesions from 3 different primary sites: lung, melanoma, and RCC. So in this study, they found that in patients in whom both radiation and immunotherapy was given, they enjoyed a far better overall survival amounting to about 52 months median for melanoma and between 18 to 27 months for lung and RCC. Now, these numbers are much better than the survival of metastatic CA lung patients, as reported by Halas et al. It is about 10 months. So, if we compare these with historical controls, 10 months survival for SRS patients who are not given immunotherapy, and compares with 18 months when you add immunotherapy agent. And they also showed that patients who continued maintenance immunotherapy, they enjoyed a better survival. So a lot of studies in this regard also, not possible to discuss all of them, but the crux of the matter is that radiation and immunotherapy combination works well for metastatic melanoma. And if we just have a look at this table, this describes very efficiently the various immunotherapy agents which are in vogue today. I have just discussed the checkpoint inhibitors, but there is a host of other immunotherapy agents, including cytokines, cell therapy, and vaccines, which are being used along with radiation in a number of disease sites, and the results are still pending. Cytokines are messenger molecules that regulate immune cell maturation, growth, and responsiveness. The currently approved FDA-approved cytokines for treatment of patients with kidney cancer, leukemia, lymphoma, melanoma, and sarcoma, like aldesleukin, interferon alpha 2A, 2B, and PEG interferon alpha 2B. The granulocyte monocyte colony stimulating factor GM-CSF is also a cytokine. It promotes the differentiation of myeloid cells and can be used as an immunostimulatory adjuvant to elicit anti-tumor immunity. It is also essential for differentiation of dendritic cells. Now, what is CAR T cell therapy? It is predominantly used for treating hematological malignancies, and it is based on genetically engineering patients' T cells by adding a gene and thus making the cell chimeric. The term has its derivation from this mythical creature, the chimera, which consists of body parts from different animals. So when we have added a gene to the T cell, the added gene encodes for development of an antigen receptor, which is called the chimeric antigen receptor, or CAR, that will help the cell bind to a specific antigen located on the cancer cells and bring about its cell death. So starting from here, the first step involves extraction of white blood cells from the patient by means of chemotherapy. The second step is engineering those T cells, adding a gene to make it a chimeric antigen receptor, then cloning it outside, and then re-injecting it inside the patient. So with this renewed vigor, the cancer cells are destroyed by the CAR T cells. The main challenge for the use of CAR T cells in solid tumors is the effective trafficking of the genetically engineered T cells to the solid tumor target and propagating this response in the hostile tumor microenvironment. Radiation can help in this matter by increasing the MHC expression and tumor-specific antigens in solid tumors and make it a more amenable target for the action of CAR T cells. Then there is dendritic cell therapy or tumor vaccines, which work in a similar manner as CAR T cells, but there is no genetic engineering involved in this. Activated dendritic cells, as isolated from the patient, they are exposed to a tumor antigen. The complex is taken by the dendritic cell precursor. The dendritic cell matures and it is infused back to the patient, and then it brings about a T cell mediated cancer cell kill. The chief cons of combining radiation and immunotherapy are that higher rates of immune reactions may occur, and the symptoms may be fatigue, rash, fever, skin disorders, colitis, GI events, pneumonitis, and also immunosuppression may occur depending on the patient profile, the age, comorbidities, the previous treatment received, the RT dose parameters that we use, and the baseline immune function. Now, I'm just nearing the end of my presentation, and I had this idea only today. Like we as doctors, for diagnosing any disease, we need a host of investigations. We need biopsy, molecular markers, imaging. Based on that, we do staging and then the treatment. It's important to understand that the immune system is also a doctor that resides within our body. It is able to fight unknown pathogens, elicit an immune response against them, and bring about a destruction. So as important as it is for us to know what the disease is, it is also important for the immune system to know what kind of disease or cancer is affecting the individual and how to bring this about. When patients come to us for radiation, generally they have so much of exposure to other therapies. They have received all sorts of systemic therapies prior, and the immune system is already compromised and suppressed. So there is little scope for addition of RT to elicit an immune response in this scenario. This calls for an introduction of RT to the beginning of the curve, so that we can use the services of the immune system in diagnosing, because after an antigenic stimulation to RT, there is increased release of antigens. There is more chance that the immune system may recognize what the antigen is and then to launch an immune-based attack. So radiation, which appears otherwise locally acting, is very much capable of generating, stimulating, and intensifying a systemic immunological attack on cancer. I thank you for your patient hearing.